Well, I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia. Well, subepithelial lesions of the gastrointestinal tract are masses, bulges, or impressions in the GI lumen when we see endoscopically, and they're covered with normal appearing mucosa. What do we do with these? Well, there are excellent expert consensus guidelines that were just issued from the AGA, American Gastroenterological Association, that will really give us some good guidance going forward and how do we handle these and manage them clinically. I wanted to highlight these and go through a couple of key messages for you. First of all, these lesions are not uncommon. They're found in approximately 1 in 300 endoscopies. 2/3 of these are actually in the stomach, and they represent a heterogeneous composite of malignant potential to no malignant potential, and I want to highlight those things as we go forward. Now, the majority of these are small and found incidentally without any signs or symptoms. If there are signs or symptoms, they are most commonly related to signs of bleeding or symptoms of abdominal pain, but these are, again, very unusual, and they can rarely cause bowel obstruction or present with metastasis. So the majority of these really depend on how we propose to manage these is defining their malignant potential, what are their surveillance recommendations or need for resection. I wanted to highlight endoscopy, forceps biopsy, and endoscopic ultrasound, and then go into the key messages from this particular expert consensus. First, the endoscopy. We do recognize a lot of these things are seen in the stomach. The endoscopic appearance of things such as pancreatic rest are very, very common. These are central umbilicated lesions, typically less than a centimeter, 6 to 10 millimeters in size. And they're also in proximity to the pylorus, 2 to 6 centimeters, and almost always on a greater curvature. Very classic type of description. This is something that may require a mucosal biopsy, but once that's defined, then you don't need to do anything further. Sometimes we see lesions in the fundus, and it creates a question of a submucosal lesion or an extrinsic compression, such as the spleen. And to assess this, sometimes moving the patient themselves and potentially rotating them or putting them more upright. The sensitivity of this maneuver is low, but it's something that the authors do recognize may be somewhat helpful. How about biopsy? Well, forceps biopsies, because we're talking about lesions that are by nature submucosal, mucosal biopsies using a standard biopsy are almost never diagnostic. There are a couple things that were recommended. One is it's called a bite-on-bite or a tunneling type biopsy. These are using typically jumbo biopsies. These have larger volume. And what you do is you go in, biopsy, open it again, biopsy, push in a little further, biopsy, push in a little further. So typically a 3-on-3 type biopsy. And these have been described to have a diagnostic yield of 30 to 40% when the lesion is in particular in the submucosa. So from the third layer, the yield is comparable to endoscopic ultrasound. The advantage is lower when lesions are more deep and arising from the muscularis mucosa, muscularis propria, and there are a variety of techniques discussed in this particular consensus guideline, talking about unroofing techniques or band, needle knife, band ligation, but again, something that the 3-on-3 biopsy, the tunneling biopsy technique is something that I found very helpful. The third comment was about endoscopic ultrasound. So this is really the method of choice for characterizing submucosal lesions of the GI tract as an adjunct to the standard endoscopy. Echogenicity is really a key here. The echogenic features are typically anechoic lesions, usually represent fluid-filled structures such as cysts, varices, or lymphangiomas. Hypoechoic represent a variety of pathologic causes that include things such as mesenchymal tumors, granular cell tumors, neuroendocrine tumors, metastatic disease, infiltrative diseases, inflammation, and don't forget endometriosis when you're thinking and looking at things in the rectum. Hyperechoic lesions typically are lipomas or fibrolipomas, and mixed lesions may be mixed echogenicity, particularly things like pancreatic rest or malignant mesenchymal tumors, or even GI wall abscesses. The typical size of this lesion, and that is less than 2 centimeters, and the presence of vascular involvement are the additional features that actually help predict the malignant potential of these subepithelial lesions. Recognize that the sensitivity and specificity of endoscopic ultrasound in predicting this malignant potential is in the range of 64 and 80%, so sensitivity is 64%, specificity 80%. And key problem here is it's operator dependent. So this is a key area where artificial intelligence may derive us better specific and sensitivity and specificity, but again, you need to be having an expert to make sure that we're getting the right and the most appropriate information. Now, when we get into the derivatives of what could this be, well, in particular, we get into submucosal lesions like GI stromal tumors, or GIST, gastrointestinal stromal tumors. Well, the discriminant here is typically size, so size matters, and in particular less than 2 centimeters. In the stomach, the gastric intestinal tumors less than 2 centimeters can be surveyed by using endoscopic ultrasound. The optimal surveillance interval is not well defined. Again, annual recommendation here is annual surveillance is the current recommendation. Larger lesions certainly could be considered for resection. Leiomyomas, these are almost always benign and almost always found in the esophagus. They represent about 2/3 of the spindle cell tumors of the esophagus, and the differentiation here requires histologic characterization. Again, this is something that we find more asymptomatic leiomyomas, and they generally don't require surveillance. But if there is any question, these again need to be surveyed, and certainly histologic sampling with fine needle aspiration, and particularly fine needle biopsy. Carcinoids are kind of the discriminant that the authors raise as a bit of a kind of a red flag here to make sure we know what we're dealing with. Gastric carcinoids typically are divided into 3 types, as you may remember. Type 1 is certainly in the setting of chronic autoimmune gastritis and is associated with hypergastronemia and a high gastric pH. Type 2 develops in the setting of gastrinomas. These are with high gastrin levels and in generally low pH and could be part of the multiple endocrine neoplasia type 1. They're rarely metastatic. They're typically low mitotic indices and generally not something that is greater than 1 to 2 centimeters. Type 3 are the red flag, however. They're not derived from any underlying gastric pathology, not related to gastrin secretion. So the problem with type 3, they often require radical resection. In a small subset, smaller lesions may be followed, but again, this starts to get into review this guideline, look at this or this expert consensus, and review this when you start to make discriminant questions. Make sure you have your histopathologist well attuned to what you're trying to look at. Duodenal duodenal carcinoids typically are non-functioning. These are localized lesions, typically found coincidentally. And endoscopic resection is preferred if possible, again, by experts. Lesions for 10 millimeters or smaller in size that are limited to the submucosa. When you start to get into larger lesions and more extensive involvement, then these are something that really require performance at a high volume center, and again may warrant surgical referral because the perforation or bleeding risk is inordinately high in the duodenal area. Rectal carcinoids are something that I'm sure you've probably all seen, and certainly the management of these depends on the size. So the current recommendations are for completely resected lesions that are less than 1 centimeter do not require any further evaluation or surveillance. Lesions that are 1 to 2 centimeters, these are by traditional transanal surgery, and they're staged as a T1 lesion without nodal involvement. And after resection, these lesions require surveillance, endoscopy, and endoscopic ultrasound at very much a 6 to 12 month interval. And granular tumors, the last comment is just to relate, these are most, again, commonly seen in the esophagus, mainly in the submucosal layer, small lesions, and they have a benign behavior, and they can be surveyed by endoscopic evaluation alone or with EUS. And the same with duplication cysts. These are things that typically do not need to be FNA'd, fine needle aspirate. There's a risk for a mediastinal infection, and if they have a classic appearance for duplication cysts, they do not need further surveillance. So let me give you the final recommendations and the consensus recommendations. First, the bite-on-bite biopsies. Certainly, if you have that question to start, histologic, endoscopic ultrasound. Number 2 is the evaluation of choice for indeterminate subepithelial lesions in the GI tract, or non-diagnostic by the biopsy forceps. If the lesions arise from the submucosa and they're sampled by the tunnel biopsies, then you do not need to have, and you have a definition of the diagnosis, you don't need to further evaluate for fine needle aspiration or fine needle biopsy or advanced endoscopic techniques such as unroofing or endoscopic submucosal resection. These, again, must be done in the hands of experts if you get into these more advanced procedures, so high volume centers is the next best practice advice. The management, the next best practice advice, is dependent on the size of the lesion, histopathology, and their assessment of malignant potential and symptoms. If there's signs or symptoms, bleeding or pain, that heightens the need for resection, and that's the bottom line. The idea of the endoscopic appearance that you see with typical lipoma, the pillow sign you see when you push with the biopsy forceps, pancreatic rest, normal biopsies, these do not need further endoscopic surveillance, and duplication cyst would be in that same category. For lesions that are arising from the muscularis propria that are less than 2 centimeters, then the recommendation is still to survey these with endoscopic ultrasound. And again, recommendation is not evidence-based, but the current recommendation is 1 year, and these are certainly things that are without high quality evidence, but that's a standard. The next best practice was gastrointestinal stromal tumors that are larger than 2 centimeters should be considered for resection. Again, when you get into these, I'd ask you to review these, in particular as it relates to carcinoids in type 1, 2, and 3. There are discriminates based on the type of carcinoids. And finally, just to reiterate, the subepithelial lesions that are ulcerated, bleeding, causing symptoms should be considered for resection, again, in the hands of expert. So I would bookmark this, I'd put it on your desktop. Next time you have a subepithelial lesion in the GI tract, refer to this. This is the best practice evidence we have to date. And Dr. David Johnson, hopefully these comments are helpful. See you next time.